Next up is Dr. Chris Ames, and really need no introduction, and he's going to talk about predictive modeling and deep learning for preoperative patient evaluation.
Good morning, and thanks Kyle, Lee, and Lionel for invitation back to this incredible course. It's great to be with you guys this morning, and I'm going to update you a bit, and I'm going to reframe things a little bit compared to how I presented this last year and show you some of the new directions we're going in terms of our data hunt. My disclosures, the most significant of which is I'm the lead surgeon consultant for Medtronic on their data systems. Well, if we try to take an example from the broadest application of medical treatment, it's really through pharmaceutical therapy. And if we look in more detail at how drugs are applied in the US population, we realize that the majority of FDA-approved drugs are only efficacious in a very small percentage of patients, and this is a very common practice. It's very similar, however, to surgical therapies, where we broadly apply, for example, adult spinal deformity surgery to a large heterogeneous population, and then we seem surprised that only a certain subset of those patients substantially benefits. This is also probably true in the degenerative population as well. We see some of my happiest patients are the black disc patients from years ago when I used to do more of that surgery, and some of my unhappiest patients were the same patients, and I couldn't tell them apart on the front end. Well, as you get more and more complicated, the situation just becomes more and more heterogeneous with variation in the outcomes. So the idea that they've used now in cancer therapy for many, many years is to try to do more of a better characterization of the patients on the front end using genetics, using receptor analyses, using epigenetics, and better patient clustering in designing trials so that the outcomes are more homogeneous. And this is an example from one of my recent chordoma patients where they did multi-gene analysis on this patient and found actually this patient was likely to respond to prostate cancer drugs because they located prostate cancer receptors in the chordoma, which was something that was a complete paradigm shift compared to how we used to treat these tumors years ago. I think we're going to see the same through the application of big data in the adult spinal deformity population. When I started, we used to just have things like age, Charlson Comorbidity Index, and maybe their sagittal parameters to try to create really a picture of the patient. And nowadays we have biomarkers, we have genetic aging, and I'll show you some of the newer technologies we're using to assess these patients on the front end, all of which can then be incorporated into predictive modeling to try to get a better, more accurate picture of the patient. Well, where did we start? Well, this journey started for me about 10 years ago in the ISSG group, where we decided we needed a better way than the Charlson Comorbidity Index to characterize patients in terms of their risk assessment for surgery. And we started doing a dive into development of a frailty index. And a good way to think about frailty is it's essentially your physiologic reserve and your response to an injury. It started in geriatrics where if patients fell down in the community and they were admitted, like how likely were they to bounce back from that and be able to return to independent living? And it's been used in geriatrics for many years. So we developed a frailty index using the standard methodologies, and it was a 40-point scoring system that we then translated into frail, not frail, severely frail, and we used that for many years to try to better characterize the risk on the front end. However, we soon realized that these indices were still not really creating this more complete portrait of the patient. In a way where if you took every variable together, you'd be able to predict better what was likely to happen to them with a given surgical therapy. A really good book on this is Eric Topol's Deep Medicine. For those of you who have an interest in the future of medical or surgical care, I highly recommend it. The idea was to take everything together, the surgeon, the facility, the patient characteristics to predict. And what we saw was in the ISSG group, and I'll show you some of the models we developed, we saw that over the years we were able to accumulate maybe 500 patients a year, 1,000 patients a year to do these predictive models, and that was going well, but we just weren't able to add enough every year so that the variation in treatment was keeping pace with the predictive models. Probably in the future, what we're going to see is that there's going to be a shift in where these models are coming from the research groups into industry, where they're now treating thousands and thousands of patients every month across the world, whereas the registry groups are only treating really about, or entering maybe about 500 patients into the registries. We can talk more about that at the end. So now I want to show you some of the unique things that I think are really going to transform our practice using AI, and some of the things AI can do that the surgeon can't do, and maybe a better way to frame it. So one of the things that the AI and machine learning can do is to better cluster patients. I mentioned at the outset of the talk, when we used to characterize patients, even if you're a well-informed surgeon, you would look, for example, at their frailty index, maybe their disability scores, their BMI, their bone mineral density, and their radiographic parameters. Well, what the machine can do is immediately assess the patient in the context of every other patient in the database. So this is a graphical representation of every patient in the North American and European registry, and it can say, okay, this is this patient in front of you in the clinic in real time. These are the patients most similar to that patient that you've treated or other surgeons have treated around the world, and these are the outcomes of these patients. So especially if you're a young surgeon starting out in practice, being able to have immediate access to similar patients, not just based on radiographic parameters, but based on frailty and other variables, and to see how those patients did treated by maybe the master surgeons around the world, I think would be really important in decreasing your learning curve and optimizing your outcomes very early on in your practice. And that's something that humans can't do. We can barely remember our last best or worst case. We're not able to match, on 50, 100 different variables in databases of 5 or 10,000 or 100,000 patients. The other thing that the AI can do is to generate risk-benefit classifications. When I grew up in spine surgery, we used Frank Schwab's classification. That was based on a weak correlation analysis, an R-squared analysis to the sagittal plane. Quite artificial, and I'll show you toward the end of the talk, highly inaccurate in terms of actually leading to significant improvements in these patients for reasons we'll get to later. But if you use clustering, you can generate this sort of risk-benefit classification, where we actually turn the machines loose and we said, okay, how many different types of patients are we really treating? The machine said, basically, you're treating 3 different kinds of patients. And then we had to go into the data to figure out what the variation in those patients was. And they said, basically, you're doing 4 kinds of surgery, which is really interesting. I thought, kind of the machine's take on what we've been doing for, over several decades. And what it does is it matches then the procedure to the patient type, and you can just read across, and it gives you your likely complication rate and your likely improvement with those patients. So rather than a classification based on a weak correlation to the sagittal plane, it gives you a correlation based on risk and benefit, which is really of much more significant importance to surgeons and patients at the point of care. Then, maybe just getting into kind of just the radiographic appearance of the patient, it can essentially do a fingerprint matching algorithm to the radiograph. This is something that industry is actively working on. I know at least 2 companies that are working on this sort of radiographic matching algorithm, much like you look for a criminal in a large database of fingerprints. It can go into databases now of 25, 30,000 patients and pull out the patients that were most similar radiographically and topologically to that particular spline for that particular radiograph. Okay, this is something that's near and dear to us at UCSF and at large tertiary referral centers around the world that are treating the most complicated patient. Because we're treating more complicated patients, often our benchmarks don't look as good as you may see in the community where they're just doing very simple cases. This is just an example I pulled a couple of years ago where UCSF didn't look as good as California Pacific and Reagan didn't look as good as Cedars, for example. And the reason that a lot of this occurs is that we simply draw an average across outcomes. This is a typical complication called PJF. How did we used to do this analysis in the International Spine Study Group? We would essentially take all the sites, we would draw an average value for PJF across the sites and say, okay, you're over or underperforming based upon whether or not you were above or below that average. Well, if you use predictive modeling based on the patients that you're treating and the types of surgeries that you're doing, and using 25, 50 variable models, you can actually predict where the individual site should be based on the complexity of the patient population that they're treating. And what you see is that some sites that were below average in terms of their rates of PJF, which looked good initially, actually were still underperforming, even though their PJF rates were lower than average. And some of the sites that had high complication rates for PJF were actually doing reasonably well based on the types of patients that they were treating. The unfortunate problem in large hospital systems is that nowadays you can go out and get like a master's degree in hospital administration online and come in and try to tell the surgeons, that they're over or underperforming, and you don't help them to build actual predictive models of, the complexity of their population. So this is still an ongoing issue for institutions that are treating complex patients, but the answer certainly lies in better models and not in limiting care to complex patients. Now, what about prediction based on 100 variables? This is something that's beyond the capability of most humans to do. There have been many cognitive studies that show that humans can at most integrate 5 pieces of information in an important decision. Much like we can't integrate 50 different radiographic measures and 50 different patient characteristics of frailty and biological age. Well, this is something that machines can do, and there have been a few earlier talks on alignment. One of the issues we still have in adult deformity surgery is getting perfect postoperative alignment in terms of segmental, regional, and global. You see a 10-degree overbend results in a negative global spinal alignment. And the reason is because there's so many variables involved, and it's very difficult for us to predict how an individual patient will equilibrate when they stand up. We're operating on them in the supine or prone positions. So this is one thing that machines can do quite well. They can take 50, 100, 1,000 different radiographic pieces of information and predict in large databases how the spine will equilibrate when the patient stands. Their ankles, knees, and hips on EOS, and in unit systems, they can predict the thoracic spine alignment, the pelvic alignment, the lumbar realignment after AIS. This is something that you'll see more and more of from the companies that are engaged in data over the next decade. Well, what about patient selection? This is probably the most difficult area for us. Raj Sethi's group used human intelligence to come up with this multidisciplinary conference system where they would essentially try to limit care to the patients that were likely to have the highest rates of complication, thinking that those patients would actually then also have better outcomes. Well, if you actually look at the data, essentially what that did was simply limit care to the patients that were likely to have lower complication rates. The patients that actually did best in this study of PSO that we published from ISSG probably more than 8 years ago now, shows that actually the older patients, the ones that had the higher rates of medical complications, actually had the greatest lift in their health-related quality of life. So if you limit care to the patients that are likely to have the lowest complications, you actually aren't taking care of the patients that are likely to improve the most. So we need more sophisticated filtering systems, probably beyond human intelligence, to do this. And as I mentioned before, you can't simply focus on the patient. You can't simply focus on the procedure. The only way to do this is by taking everything together to come up with the best ways to predict. And we've come up with predictive models of complication. These are the data points that we were able, this is the accuracy rates we were able to establish in a collaboration with the European Spine Study Group and the International Spine Study Group years ago. And what you see is that the accuracy increases as you add more and more data points, even up to the point of discharge, where you can assess a risk of readmission or reoperation and probably increase the touch points of that particular at-risk population to limit their readmissions and reoperations, which will help your quality measures. This is that exact model and some of the papers that we published around it, showing that we can individually map a patient's likely complication course after surgery. What about outcome prediction and precision prediction for an individual patient? I mentioned before that if you apply average values to large heterogeneous populations, you're going to be inaccurate in about 5 to 10% of the, or you're only going to be accurate for about 5 to 10% of cases. This is what we had done before. If you were to counsel a patient on their likely outcome, what would you do as a good doctor? How do you go about telling a patient how they're likely to do from a complicated procedure? Well, if you're an educated surgeon and you're diligent, you would go to the literature, you would pull out the largest series from those patients, and you'd quote them average values from papers, right? But that's essentially lying to about 90% of the patients because there's such variation in outcomes. So the better way to do it is to use predictive models. We came up with a 75 variable model, which was about 75–80% accurate, and we published this years ago, showing that you could individually predict, based upon the surgeon, the site, the procedure, and the patient's risk characteristics, how they were likely to do after surgery. And all prior to surgery, we could generate their 2-year likely outcomes across all the different domains of outcome, SRS-22, ODI, NDI, et cetera. The other interesting thing is that if you can predict all of this on the front end, what else can you do? Well, you can run simulations. You can say, what if I wait 5 years, you deteriorate more, and you stop smoking? Or what if I stop at T10 versus I stop at T4? You can do all these simulations all prior to operating on the patient to better plan your surgery and when you should pull the trigger on a major intervention. Well, finally, in terms of optimizing decision-making, one of the other things we can do is to improve our ability to see beyond our own individual human bias. Those tabletops were exactly the same length. My son is here. He actually measured those for me to show that they were exactly the same size. So the human eye, whether you're looking at a patient or a tabletop, can lie to you, and you can't be trusted. Good books on human noise and bias is this one by Daniel Kahneman, who recently passed away. And then this is one of my favorite books, Thinking in Bets, written by a neuropsychologist who's also a poker shark. My favorite human bias that she describes in the book is something called resulting. Resulting in poker is where you make a bet and you lose, and you think, God, I shouldn't have made that bet because I lost. Same is true in surgery, where you operate on a patient, they have a major complication, you say, well, I'll never do that again. But that may have been exactly the right thing to do, it was just bad odds. And so if you adjust your behavior based on just anecdotal experience, you're probably doing the wrong thing. So we tested this in surgery. We went through into the ISSG and ESSG groups, and we gave them case scenarios, and we asked them to predict the outcome from surgery. So you could imagine this being like an inexperienced surgeon shows the case to 10 experienced surgeons and says, what do you think? Should I operate on this patient? Well, if you look at case 7, predicting major complications at 2 years, one of the surgeons said the likely complication rate is 1%, and one of the surgeons said the likely complication rate is 100%. So it's not very helpful in terms of trying to decide what to do. Probably unbiased predictive models that are constantly increasing in accuracy through the addition of additional patients is probably a much better way to go. Well, one of the things that's near and dear to all of us in modern medicine is cost effectiveness and resource utilization. This is where these predictive models can be most efficacious, probably. If you compare operating according to surgeon opinion versus operating according to predictive models of QALY, the QALY gain per patient was over close to 700% greater if you operate according to what the machine recommended versus what humans did. Just let that sink in for a second. If you don't think this is going to come to your surgical decision making, you're lying to yourself. There's no way. Now we can predict cost outliers with about 90% accuracy, and we can predict dollar cost of surgery, really down to almost the dollar, the decile of dollar. And that allows us to then do things like this, to go to for example, if a large company had large databases of radiographs and outcomes, that were 20,000, 100,000 patients. They could go to the NHS, they could go to the healthcare system of Spain, and they can say, let us help you decide how to spend your money. What if you say, okay, I'm going to draw a major complication filter of 50%. I'm going to tolerate a 50% complication rate, but I'm going to demand a 50% chance of reaching minimally clinically important difference. You say, well, these are the patients you can operate on. This is where your results are likely to be. But patients don't want to know what their ODI is going to be. That might sound cold, okay? You're going to be able to predict outcome and cost, so you're going to start limiting care. But let's try to warm that up again and think about what's really important to patients. How could predictive models improve empathic care? One of the ways that it can do this is by trying to match the procedure to the patient preferences. So what if I could predict, will the patient actually walk better if that's their goal? Or will they be able to care for a loved one better? Or will their mood be better? Will they be less depressed? If I could predict that and then match the procedure to that, that was likely to be a more satisfied patient. Well, actually, our most accurate predictive model was a model of the SRS-22 individual question answers at 2-year follow-up. All these questions are, will I look better in clothes? Am I happier? Will I be able to return to work? Is my back pain less? These get to very specific patient preferences. Like, for example, in this example, patient wanted less back pain at rest, and we could predict on the front end, the likelihood of that was about 77%. And then post-op, patient didn't have a complication, we can adjust the model that the likelihood is about 80%. And then finally, one of the really interesting things that the models can do is to teach us things. And I think we'll learn a lot more about our patient populations when we start looking at what the models are telling us. And let me show you. One of the great examples of this is Move 37. Is anyone familiar with this from Go, AlphaGo? Essentially, I always thought that if you watch the machines play a game, that they would just wear down the human competitor with a series of like Dr. Spock, like very logical moves. It would be very boring, but they would eventually just beat the human. Well, that's actually not what you see. They make very radical, crazy moves. So when they were playing this game AlphaGo, it made this Move 37, and all the masters thought, oh, the computer just lost the game. But actually, it was such a crazy move, the computer won immediately, and that was the winning move. So it taught them to think differently about the game Go, and I'll show you where it's taught us to think differently. So we used to think that the surgeons were so critical in complication rates, even at the benchmark levels. Like, there are many surgeons in our group that have huge egos, and they're like, well, my results are just different. You can't compare I'm not going to mention any names, but you can't compare my result to the results of the ISSG or something. I'm such a much better surgeon. Well, actually, does anybody have any idea the impact of the surgeon on complication rates in the International Spine Study Group? How many think it's about 30%? 20%? It's about 5 to 10%. And how about for ODI? Change in ODI score, it's 2%. It's not the surgeons that are making so much difference, it's actually the patient population. And that was something we learned by building predictive models. We saw that actually the modifiable variables are really important. The other thing that we learned is in outcome prediction. So look at the top outcome predictors from adult spinal deformity surgery. This is all on the pre-op side. Do you see post-op SVA anywhere there? Do you see post-op pelvic tilt? Post-op alignment change? No. We actually asked our predictive modeling expert if he could predict the ideal alignment for a patient to optimize their outcome. And he came back to us and said, sorry, I can't do that. We said, why? I mean, it makes sense. If you can predict the outcome, you should be able to predict the optimal sagittal alignment that would make the most difference in the outcome. He said, sorry, I can't do it because it doesn't matter that much. Nowhere in the preoperative variables that to predict the post-op do you find post-op alignment change or anything like that. So we went back, based upon that finding from the predictive modeling, what the computer taught us, we went back and looked at the R-squared values now in a much larger population. So remember the Schwab classification, all based on the R-squared values? Now, the post-op correlation or impact of alignment of 2-year SVA versus ODI is 5%. That's how much the post-op SVA matters in your outcome from surgery. So now in just the last minute, I'll just kind of show you guys some new stuff. One of the things we realized was adding more and more patients, we're not improving our predictive accuracy. So what has research in predictive modeling become? It's become a variable search. We are now looking for new variables, not trying to come up with different neural networks to make our models better. Look at, for example, the relationship between SRS activity and 4-meter walk. So a subjective reported metric versus what someone's actually doing. Okay, there's no relationship. You're like, how do you walk? I walk really well. And then you actually measure their walking, it's terrible. And vice versa. So if you're using this metric, a SRS activity, to predict their outcome, it's not going to be as accurate as if you were actually creating digital twins of the patients on the front end. So let me show you some things that we're doing, and then I'll finish up. One of the things we realized we weren't considering enough in adults was the topology of their appearance. So we started using technologies, photography, as well as 3-dimensional mapping, to better create heat maps of their physical appearance prior to surgery. I was told many lies when I was training in spine surgery. One of which was, if the patient's fused, the rods never break. That's a lie. The sagittal plane, that was a lie. One of the other ones was, appearance doesn't matter in adults. It only matters in pediatrics. That's a lie. Actually, the latest research shows appearance is probably one of the most important parameters in outcomes. So we figured out different ways to do this. We now, on all of our patients in my practice, they all get this 3-dimensional topological map prior to surgery. What is this allowing us to do? It's allowing us to digitize the information to create variables that we can use for prediction. I mean, that's basically the bottom line. And we can create volumetric analyses that compares pre to post-op and heat maps of what changed in their body characteristics pre to post-op. I just flipped through some of this. And then finally, there are a lot of companies now that are entering the space of realignment and custom rods, for example. But one of the elephants in the room is that these are all architectural plans and not engineering-based plans. You can't build true plans that are purely geometric. They have to also be based in force and engineering data, and you can't generate those plans purely based on finite element analysis. You need dynamic data in order to build those plans. So one of the reasons that the sagittal plane probably doesn't matter that much in a standing X-ray is we don't spend a lot of our time standing erect, straight up. We spend most of our time doing dynamic things, moving, bending. And so we've started, again, trying to measure this in our patients. All of my patients get measured on the Movelda system. We now have over 150 patients that are completely digitized in terms of their gait in the adult spinal deformity population. And through one of our collaborations with a lab, sorry, I just want to show you guys that, from at UCSF, Jeannie Bailey's lab, which is an orthopedic musculoskeletal lab, they've developed this comparative data point image of patients walking pre-op to post-op. So this gives us actually numerical data we can use to predict outcome, rod fracture, screw loosening, pseudoarthrosis, all based on dynamic pictures of the patients rather than a single static picture. And what you can see prior to surgery, the patient has a lot of eccentric body movements, whereas post-op, the patient is much more well-constrained in terms of how they move and the stress they put on the system. So let me just show you, to finish up, the current modern data portrait that we're generating on these patients. So we have a typical pre to post-op adult scoli. We do the topological body image of the patient. Of course, we do biomarkers. I won't go into that so much in this talk. And then we do a test of their sarcopenia. We do grip strength, timed up and go, muscular circumference data. We use an in-body impedance machine to measure their body composition pre-op and post-op. and you can see many of our patients have an increase in skeletal muscle mass in the post-op period as they're becoming more active. We measure all this pre to post-op. We measure, obviously, their biomarker data and their Levine age, as well as their telomeres and their Dunedin pace, which is their instantaneous pace of aging. And then we use force plate data, which is we collect using a walking mat, looking at the eccentricity of their steps and how they're loading their feet as they walk. And we compare this, again, pre to post-op, and you can see differences in the way that these patients are walking after surgery, with usually greater stride length and less imbalance of their trunk system. So I think I'll stop there, and happy to take any questions on the future of the variable hunt, which I think is the most interesting area.
I couldn't help but notice that most of your patients were a little larger. How much would it change things if you made them lose a few pounds? And would the insurance company insist upon it? Yeah, well, BMI is, I think, the way that we used to assess patients. You know, many surgeons still use BMI. I think we need to be more sophisticated now and actually look at more body composition. We have many patients that appear to be, for example, normal body weight, that have very poor muscular muscle system. They're sarcopenic. Some patients that are overweight that have really good muscular systems. So while I agree with you that BMI is one simplistic variable, it's a much more complicated question. It really has to do more with their muscle and their general health and some of their other biomarker data, probably just in whether they're obese or not. One of my ex-fellows who's not here recently looked at PSO outcomes in obese versus non-obese patients. There was no difference in how they did post-op. So it's not as simple as looking at BMI, but it is one part of the equation.
Chris, thanks again for that wonderful talk. I have two questions for you. One is that between man and machine, in terms of making decisions, there's typically an iterative process. What does that look like going forward with the stuff that we're doing? That's one question.
Sorry, what was the last part of that? I didn't hear.
What does that look like going forward, the iterative process between man and machine? I'm talking about
Oh, I
surgeon and
see.
machine.
I see what you're saying, yeah.
That's one question. And the other question, and I'll let you answer, is I like the lies in spine surgery that you talked about. So what are the truths that you discovered? If you can just, maybe
Sure.
give us a top tip.
I think it's going to look a lot like, what we see in aviation, which is where, there's a pilot who's ultimately responsible for the plane, but they're receiving a lot of enabling technological information. I mean, that we had a first talk on navigation that was enabling technology that was, really transformational. But now we have data systems that are really maybe more of the ultimate enabling technology in our decision making. So much like you use navigation to place a screw, you'll use enabling technology of data to make decisions on who you should operate on, what surgery you should do. It's not going to be the ultimate decision maker, except maybe on the insurance side, but it's going to give us interesting information, like maybe you should lose a few pounds, or maybe not. Maybe you're obese, but your sarcopenic score is quite good, so maybe you can just proceed. I think it's just going to more information about the likely future that's not subject as much directly to human bias. I mean, there's bias in terms of who's included in the database, but there's not that much bias in the individual decision making. I think that's what we're going to see for the next 5 or 10 years. And the other thing we're going to see is that there's going to be a shift to industry, where it's not going to be the registry so much anymore. We add 500 patients a year. Some of these companies touch 2 lives a second. So there's, our days as, leading this as registries is over in the next 5 or 10 years. It's going to be large companies that have, huge data footprints. And the truths are that it's much more complex than we thought. And aging and understand, just like, spine surgeons say we had to own the bone. I think we're going to have to own the data systems in a way that where we really understand what's going on. And it's much more complicated, and it has a lot more to do with variable interaction than merely looking at very simplistic things like BMI. There's a big interaction between surgeon-patient type, procedural type, frailty, bone density, radiomics, and that's, we can at most make decisions on 5 pieces of information. If you think about the future of surgery, we're going to be called upon to make decisions that involve 200 pieces of information. We can't do that as humans. We'll have to have some integration from the machines to help us figure out how to process 200 pieces of information per patient.
One last question by June.
Hi, Chris. My name is June. Yeah, so you mentioned that you're on the hunt for variables that I guess help you better predict outcomes or prognosticate. But I've also noticed you're doing a lot of deep learning research, which those algorithms create their own variables, right? Without us having to, I guess, dumb it down for them. So if you put in the raw data, like the EOS X-rays, their gait analysis, without you having to, simplify it into featurized variables, has your group looked at just putting in, X-rays, genomics data, stuff like that, and just letting the algorithm kind of black box spit out, predictions?
Yes and no. I mean, we've still entered categorized variables. The closest we came to we used unsupervised learning to create the clusters, but it's still based on annotated data that we entered. The European Spine Study Group is looking at unstructured data in X-ray data. So that's quite interesting because there's a human bias in what we think is important. Right. I think we're still a ways away from going to like raw pixel density data in radiomics, at least in spine surgery. But I agree with you. In the future will be not to use human annotated data, but to use raw data from the charts, raw data from the images. Absolutely.